Hello, everyone. Welcome to this webinar this evening. This is ultrasound-guided injections and everything you need to know. And with us this evening, which we're really grateful for, is Chris Myers. He's very renowned within the physio, osteo, and sonography game, and is a world-renowned lecturer and trainer within ultrasound. And tonight he's going to talk to us about ultrasound-guided injections, which I'm sure you're all really excited for. Just to give you a bit of a background, those who don't know PhysiQuip, we are a distributor of medical devices, medical technology, including focus shockwave and diagnostic ultrasound primarily. So if any of that is of interest, feel free to reach out to us and we can help with that. But I also wanted to mention we have got a few polls which will come up as and when. Those polls are going to be used just to give us an idea of where everyone's at in the room. This is going to give Chris some information as to where everybody's at, and then he can help tailor his presentation to who's in the room today. So yeah, on that note, I'll hand over to Chris. Take it away.
Are we going to do these polls now, Jack?
Yeah, so they've come up on screen. So yeah, we're just waiting for people to vote, I believe. Yeah.
Okay, let's wait for everybody to do that, and then I can get an idea of who's on the webinar.
Brilliant.
But while we're doing that, let's get started, and I'll come back to it. If you interrupt me when you get the results, Jack, and I'll take it from there, and you can let me know. Is that okay?
Yeah. Yeah.
Okay, so thanks very much to Jack and the guys at PhysiQuip for inviting me. We did a similar sort of lecture. I think it was during the first or second lockdown. And I'm more than happy to come today and talk about ultrasound-guided injections, which is something I do a lot of. And the reason we wanted to do this webinar is because I run the Sports Medicine Ultrasound Group with Rob Louse. And we're getting more and more people asking about, well, I want to start doing ultrasound-guided injections. What courses do I need to do? What skills do I need? What knowledge do I need? What supervision is available, et cetera, et cetera. So hopefully we'll be able to answer some of those questions today. I did see that there was loads of questions came through from the delegates before. So what I thought I'd do is try and get through my presentation as quickly as possible, and then hopefully we can have a bit more of an informal session answering some more specific questions. So I'll get started and then we'll take it from there. So this is what we're going to cover. So what skills do you require? Start to think about the different learning pathways that are out there and are available. Certainly thinking about what does it take to get good at ultrasound-guided injections. And give you some tips along the way that will hopefully help you if either you're thinking about doing injections or if you're currently doing ultrasound-guided injections. So just a bit of background. I've got two roles. I run Complete Physio with Dave Baker and Dave Luca in London. We've got 5 clinics and we all met as extended scope physios, which is obviously a bit of an old term now, but we were carrying out lots of diagnostic ultrasound guided injections in the NHS. And we pretty much picked up what we were doing in the NHS and set that up privately. So Complete Physio does have there's lots of us that have done sonography training. There's lots of us that have done independent prescribing. So we like to provide that sort of one-stop clinic to patients where they can come in, get a clinical assessment, get an ultrasound scan, and if appropriate, carry out an ultrasound guided injections. I personally, this is a bit of an old slide, I probably do around 600 to 700 injections a year. And as a clinic, we probably do 2,000 to 3,000. So it's every year. So it's an awful lot of injections at the moment. And it's something that we've developed in private practice. And it is a unique selling point that we have. And I'm very passionate about teaching people how to do diagnostic ultrasound, how to integrate it into their practice. It's not an easy thing to do, but it's definitely possible. And obviously how to integrate ultrasound guided injections into a private practice, because that does come with lots of barriers and it does come with lots of things that you need to consider along the way. My second role is, along with Rob Louse, is the SMUG group, so the Sports Medicine Ultrasound Group. And so we teach lots of people how to scan and lots of ultrasound-guided injection courses, both university accredited, but also just more, day courses or attendance courses, if you like. So that's a little bit about my background. In terms of
Chris,
yeah,
just before you go ahead, we do have the results for the polls. We can share
the results
those.
are in.
Yeah, we can share those with you now. Just wanted to give the heads up there.
Yeah.
Can you see those?
Yeah, and this is what we find in ultrasound, and I've been teaching today, and I've got some people in front of me that I was teaching, is ultrasound brings so many different disciplines together. And so that's probably a fair reflection actually of our SMUG courses, where you predominantly get sort of sports doctors, GPs, physios are probably the two biggest groups that we get, and then you do get others, osteos, sonographers, radiologists, etc. So that's good to know. Have you got the next one?
So scroll down.
Oh yeah, guided injections. Okay, so we've got quite a few people. Okay, good. So this is what we were trying to set up, was a course for sorry, not a course, a webinar where people are considering doing ultrasound guided injections but aren't sure what to do next. So that's good. And obviously some of you are doing unguided injections. So we'll talk a little bit about that later. So that's good. In terms of, thanks for that. In terms of the injections, sorry, let's go. Injections or carrying out ultrasound guided injections. These are just an example of two ways that you can do a sub-acrominal bursa. So you can see the needle coming across here. This is the humeral head. This is the supraspinatus. This is deltoid. And then you can see the bursa, that is this thin slip of fluid, if you like, or potential space, which is between supraspinatus and deltoid. So you can see as you put the fluid in, and it's the same down here, but this is a long section, you can see that you distend the bursa, and you can see that you're lifting it up there. You could do that with an orange needle under ultrasound guidance. There's no way without ultrasound that you can confirm the placement of your injectate into the bursa. So that's a more sort of basic procedure. But what's great about ultrasound is you can start getting into some more exciting procedures. And this is from Mike. Mike, some of you will know, I teach with him on our cadaveric course, very skilled practitioner. So this is a barbotage. So this is calcification. So you go through the calcification and then you get this pumping action going. This is a really effective procedure for calcific tendinopathy. And you can see on this one here, as you start, this is just saline, maybe a bit of local. You have to use quite a large gauge needle, and you can start to see this sort of cloudy substance, which is the calcification, coming back into the syringe. So using ultrasound guidance allows you to do more advanced procedures, such as the barbotage and lavage, which obviously you wouldn't be able to do without ultrasound guidance. This is a hydrodilatation or hydrodistension. So this is the humeral head. This is the labrum, acetabulum, infraspinatus, deltoid, and then you can see the needle coming down, lifting up the capsule. This is the fluid here that you're pumping in. This is using a three-way tap, and you can see that going nicely. And again, we know that unguided injections are about 50% accurate for going into a posterior joint recess of the shoulder. And so obviously, if you're doing something like a hydrodilatation or hydrodistension, you need to make sure that you're in the joint. And obviously, ultrasound guidance gives you that ability to distend the structure that you're doing. So that's just a couple of examples of what ultrasound can allow you to do. And there's certainly, when you're looking at learning pathways, you're not going to start with a hydrodistension or a barbotage procedure. You're more likely to start with something more simple, like a subacromial bursa, or an AC joint, or a knee joint, ankle joint, something like that. So certainly when you're embarking on your training, it is good to get started with some of those simpler procedures. It certainly can be a bit of a confidence game, and if you start with more tricky things, then it's going to knock your confidence a little bit. So this is a question I get asked quite a lot, and quite a few of you do carry out unguided injections. Now, I'm not saying every injection needs to be, in fact, no, I am. So personally, I would do every injection ultrasound guided, because that's what I do. I'm fully aware that not every injection needs to be ultrasound guided. But I think the argument of, guided versus unguided, certainly if you're quite biased towards unguided injections, then some people will, say, well, the outcomes aren't any different. And I'm absolutely fully aware of what the literature shows, and that there is some evidence for showing that guided injections are better from an outcome point of view. But it's quite hard just to make a strong argument on outcomes, because there just isn't the data. Anecdotally, I feel that, and I've done both, by the way, so I feel that ultrasound guided injections are do give you better outcomes. What ultrasound guided injections are is accurate, and what unguided injections are is, in lots of cases, I'm not going to go through all the different cases, most of you will be aware, but there's lots of cases where unguided injections are not accurate enough. I was doing unguided injections, and before I started using ultrasound, I was, sometimes quite confident that, for example, I was in the glenohumeral joint. But when you start scanning and you start looking at what you're actually trying to, or the space that you're trying to get into, I quickly wanted to go away from unguided injections. The other thing I found that I was doing with unguided injections, again, the shoulder is a good example, is that people would come back in, and the outcome, for example, for a frozen shoulder, if you're doing a guided injection for a frozen shoulder, it's fair to say that most injections give some sort of relief. But when I was doing them unguided, it was a lot more hit and miss. And I remember saying a few times, well, maybe we try a second injection. So I do think because you're in the joint with a guided injection, I do think that it avoids lots of unnecessary injections where you may say, well, let's try one more. And I certainly hear that quite a lot. So if we look at this slide here, if we just start at 12 o'clock, so as I said there, I think it can reduce the number of sort of unnecessary injections. The accuracy argument is a very strong argument to give if you're trying to justify guided injections. So things like hips, they shouldn't be done unguided. I think most people would accept that. Certainly if you're trying to get into a shoulder joint, then the accuracy argument is obviously much, much better with guided. The AC joint is always a good one. So depending on what you read, but it's safe to say anything from sort of 30 to 50% of AC joint injections go in the joint with an unguided injection. So although the AC joint is very superficial, the evidence shows that it's very unlikely that you're going to get into the joint more than 50% of the time. Job satisfaction. Now, for me, I actually think not just job satisfaction, but career opportunities. I put earning potentials in brackets there, but I think, it's particularly if you're going to spend out on a lot of equipment, there needs to be some sort of return there. So personally, in terms of my own career, having ultrasound and ultrasound guided injections really has made a difference to the opportunities that are available to me, but also my own personal satisfaction in the job. I didn't enjoy doing unguided injections. And it's not something I would ever go back to, whereas having a skill that you can do is very satisfying. Patients love it when it's ultrasound guided. They love having diagnostic ultrasound added to your clinical assessment. So patient satisfaction is much higher. And also it allows you to develop new techniques. So things like barbotage, things like high volume injections, because you've got that accuracy there, you can now start thinking about, doing a few more high volume injections or adding a different sort of repertoire to your injections. The other thing, and this does link in really, I think this is really important, is from a medical legal point of view, it allows you to have evidence of the placement of your needle. So, and that's really, really important. And particularly if you're going to start thinking about doing guided injections in private practice, and I have, lots of experience of this, It's sometimes hard to explain, but it really does open you up to medical legal, probably more than if you worked in the NHS, because you really are out there on your own. So if you've got evidence of that needle placement, a video of you doing it, that's very, very powerful stuff if you ever did get stuck. And so that's really important. So we always save an image of the needle in position or a video, and we back all of that up. We've got a pack system that we're now got in place. So there's lots of things when you're implementing guided injections into your private practice that you need to consider and you need to set up. Less painful. I could do a knee with an orange needle. I could do a bursa with an orange needle. So often, it does allow very easy access into a joint or easy access into a soft tissue, particularly as you get better at it. So I think they're less painful, obviously, because, say, for example, if you're doing a dequervens or you're doing a perineal tendon or something like that, you need to make sure you're in the sheath of the tendon, to obviously try and avoid things like depigmentation, fat atrophy, and that sort of thing. So anecdotally, and there is a small bit of evidence for this in the literature, but I do think anecdotally there is less chance of getting those side effects such as depigmentation because your accuracy is much improved. The other thing that I think is very important is the idea of you doing a diagnostic injection. Now, obviously, if you're doing it under guidance, you know what structure you're in. And so it's not uncommon, particularly with more complex patients or patients that aren't improving, that I may just do a local anesthetic guided injection, for example, into the AC joint, if I'm finding it difficult to differentiate AC joint from bursa, and see if that changes your pain. So I may get them to do their aggravating factor. So I had a lady last week where I got them just to do their aggravating movement. I injected a little bit of local anesthetic, gave it a few minutes, got them to retest, and their pain had gone. And so, although I'm not saying it's not a scientific experiment, I am saying that may help you to guide where you want to pop the steroid. We've talked about patient satisfaction, and then what really is the thing that I think sells ultrasound to many people, including the patients, is the fact that you can provide that one-stop shop, which means that they can get the assessment, they can get the scan, and they can carry out an ultrasound-guided injection. But for me, forget all of that. The most important thing about doing an ultrasound-guided injection is doing the diagnostic ultrasound scan before the guided injection. Because at the end of the day, all we're trying to do in the first place is to get the right diagnosis. And so you can argue till the cows come home about whether you should do an injection guided or not. That's fine. What I'm more interested in is getting the right diagnosis in the first place. Now, clinical assessment is always what we should hang our hat on. It is the most important part of the process. I'm fully aware of that. But if you can also gain a bit more information from the ultrasound, then I think that can give us very valuable information about whether or not and where we're going to do an injection. So it's very difficult just to have that argument, guided versus unguided. There's so much more to it, in my opinion. Okay, so let's just go through what skills you need. Well, to keep it very basic, you need to be able to scan, you need to be able to do injections, and you need to be able to prescribe, depending on what your background is. Okay, now I'm a physio, I'm an independent prescriber. So in private practice, if you're going to start thinking about doing injections and injecting steroid or other drugs, including local, then obviously you need to do independent prescribing. The other question, or the other thing that often comes up, is people say to me, I don't want to do diagnostic ultrasound. I just want to use ultrasound to do injections. And that, I get that argument, but it's not really what I want to try and promote. What I want to promote is people that gain diagnostic ultrasound skills, they develop their injection skills and start doing ultrasound guided injections. So if the better you are, at diagnostic ultrasound, as in scanning, having the probe skills, the motor skill, being able to produce really good, clear quality images that you can make a diagnosis from, the quicker you will pick up the ultrasound guided injection side of it. So for me, it's not just about doing an ultrasound guided injection, it's about developing those skills and then also developing those injection skills alongside it. And essentially, you know, people always talk about, well, how do I get competent? How do I, you know, prove my competency? And we will come on to that. But I was competent, you know, in theory, you're competent after 35 injections, according to our postgraduate certificate. But actually, after 35 injections, you are competent in the eyes of academia, but in no way are you proficient, and in no way are you good at what you're doing. So it takes, I think, around 200 and 250 injections. And this is sort of made up numbers, but, you know, because there's very little evidence out there for it, to get to what we would call a proficient level. So competency is one thing, but actually, to be a confident practitioner, you know, that can do lots of different types of injections, in plane, out of plane, subtalar joints, PIP joints, big joints, small joints, soft tissues, big structures, small structures, that takes a long time. And one of the biggest issues you have, particularly if you work in private practice, is to get the patient numbers through the door to get good at it. I was very lucky. I was in the NHS, where you may do 15 frozen shoulders a day. And in private practice, that could take you a year, 2 years to get to those sort of numbers. So yes, I understand that lots of people want to do ultrasound guided injections, but are you actually in the correct environment with the correct supervision to be able to do it? And that's something, that's just something really to sort of ask yourself. Okay, I said 500. Okay, and also you need to think about what your own competency is. So, you know, if you're a physiotherapist and, you know, you're working, you know, with all parts of the body, then you probably need to become quite proficient, or at least competent, at doing lots of different types of injections. We quite often get hip surgeons that come on our cadaveric course. They don't have great ultrasound skills, and they just want to be able to do ultrasound guided hip injections. And that's what they want to become competent in. So actually their learning pathway is going to be a lot shorter than somebody else's learning pathway, because particularly when you look at surgeons, they do have good hand-eye coordination, and I've seen it, they do generally pick it up quite quickly, but they're trying to just use ultrasound for a specific service that they're trying to develop, which is great, because there's no requirement, there's no need to do a fluoroscopy guided when you can do an ultrasound guided and do about, you know, double the number of patients on that list. So it just depends. We've got shoulder, I was speaking to a shoulder physio the other day, and they just want to develop a hydrodilatation service in the NHS. And so they're looking at their competency and their training pathway to ensure that they get good at doing hydrodilatations, which is not the easiest injection in the book, but certainly if you can add that to your repertoire of what you do, you can make a massive difference, obviously, to patient pathways, waiting lists, and ultimately patients' pain. So you need to think about exactly how you're going to use ultrasound, and you need to obviously try and look at what guidance there is out there. And to go on to what we're talking about in a minute, there's not a lot of guidance out there as to exactly how many injections you should do, how many supervised injections you should do, etc., etc. And a lot of it, certainly when it comes to our courses, we've looked at things like the RCR guidelines, the FSCM. From a physio point of view, there's not a lot of guidance out there from the CSP, but you can sort of extrapolate some of the other information to try and put together something that you feel sort of works in terms of getting that basic competency. This is a motivating slide. This is on cadavers. So people often say, well, how long does it take to get good at ultrasound guided injections? It's quite a difficult answer, but this was on cadavers, which is very different. Although it's quite similar technically, it is very different because obviously patients, you know, screaming in your ear and that sort of thing does make things a little bit more difficult. But this showed actually that after 2 hours of practice, either it was orthopedic consultants, I believe, but also medical students, after 2 hours got 95% accuracy on their ultrasound guided injections. So although there is a long learning pathway, and there is, for certain things, that pathway can be quite short. Now, it's not going to be that if you're doing a glenohumeral joint injection, for example, but an AC joint, very superficial. And from a technical point of view, when you're scanning, it's not too difficult. So that's just something to bear in mind. And then also, depending on your we get lots of people from lots of different professions, surgeons, radiologists, GPs, physios. So have a look at this according to what you are. So for example, as a physio, generally at undergraduate level, we don't get ultrasound skills. That takes time to develop. As a sonographer, you obviously do get those probe skills. As a physio, we do get anatomy, although it is quite different from an anatomy book to an ultrasound. We don't get injection skills, we don't get the pharmacology knowledge, but we do have the assessment skills. So depending on what your job is and what your profession is, it is going to depend on what skills you need to personally develop. So that just gives you a few ideas there. In terms of how to get good at ultrasound-guided injections and just starting to think about the learning pathways that are available, the first thing to do is to look at what of those things that we've just been through on that last chart, what knowledge are you lacking, what skills are you lacking, and what do you need to do to fill the gap. So if we just start up at 12 o'clock, obviously you've got to do some relevant courses. Now, for some people, that may be a university-based course, or it's going to be more of or it may just be a non-accredited, non-university based course, but it just depends. So for example, as a physiotherapist, you do need to do some sort of accredited course, it could be an unguided injection course, but you do need some sort of postgraduate course if you're going to start injecting as a physiotherapist. You also need ultrasound skills, and we've already talked about that. If you want me to give you a rough idea, remember, the better you are at ultrasound, the easier ultrasound guided injections are, but you probably need an absolute minimum of 3 to 6 months of regularly scanning, which in my eyes means around 20 scans a week. Okay, now that is no evidence for that, but it's quite useful just to put some figures out there. The reason I say that is if you've got access to an ultrasound machine half a day every 2 weeks, it's very unlikely you're going to get anywhere with this sort of learning pathway. You need those injection skills, as we've talked about. You need some sort of supervision. Now, the biggest barrier to ultrasound learning, both diagnostic ultrasound, but also ultrasound guided injections, is how do you get that supervision? I was in the NHS, so it was all set up really, but that is particularly in private practice, that is very difficult. And on our postgraduate certificate, you have to do 35 supervised injections. And remember, that just gets you to that academic competency sort of level. You also need access to clients. So if you're in the NHS, quite often there is an abundance of clients waiting for you to inject them. But in private practice, again, it can be a little bit more tricky. I see lots of sports docs that work in football, and I totally understand that they don't want to inject the £20 million football player for the first, as their first injection. So, you've got to make sure you've got access to the right clients that you're going to be able to inject. And obviously, if you're a doctor, you've got the form, you need to be an independent prescriber. There are other ways of getting drugs. In private practice, I would suggest you do need to be an independent prescriber, because otherwise it's a very long-winded way of getting your drug, and you're very unlikely to ever get the numbers that you require. But obviously, if you work in the NHS, then you can work through a PGD or something like that. So that just gives you an idea, and you need to think about what are you missing? What do you need to develop to get good at this? Don't know why I put those green arrows in. So I'll just give you my pathway. So trained as a physiotherapist. I then did so this is before ultrasound, I did my master's at Queen Mary, and as part of that was a postgraduate unguided injection course, part of the module. So I got that, according to the CSP, that's what I needed to get. Then I went to Canterbury University and I got my postgraduate certificate in musculoskeletal ultrasound. So I started to do my unguided injections. As soon as I started doing ultrasound skills, I thought I'm really not comfortable with unguided injections, because I started to realize I just didn't know. And until you scan, you don't know what you don't know, do you? So it really opened my eyes. And as I started to see more and more patients that were suitable for an injection, I started to do ultrasound guided injections. And I was very lucky that I was in a department where we bought in the time of somebody that could supervise these injections. So we came up with about 50 that we did. And then we did a logbook, and this is really important because this is your evidence of learning. You need a logbook of the injections that you do. So if somebody says, well, what is your, how have you got to this level of skill? Why do you think you're competent? How have you developed this knowledge? Then you can show them your logbook and say, well, this is my evidence of learning. And then I did at University of Hertfordshire, I did my independent prescribing, which then meant when I left to work in private practice more full time, I could then do injections in private practice. Obviously in the NHS department, I was working under a PGD, which allowed me to get the drugs without being an independent prescriber. So I've just written you can have a look at this in your own time. I'm happy to send these round, but you've just got to start mapping out what you need to do. Now, as a physiotherapist, your learning pathway may be quite different to a radiologist or a pain consultant or an orthopedic surgeon. I'm not always sure it should be, because at the end of the day, it's the same skill that we're trying to learn. But I do think that you need to try and put those different components together, and what that means. And we'll come on to questions in a minute, and maybe we can start talking about a few individual cases where you need to develop it. But that's essentially what you need to be able to develop. That's what you need to be able to go through as a learning pathway. So just to finish up, in terms of getting started with ultrasound-guided injections, hopefully this webinar starts to make you think in the right direction. And there's obviously lots of things you can do. You can practice doing it on meat specimens. The best thing I think is is to develop your ultrasound scanning skills before you start doing injections. It will certainly be a lot easier. And also the other thing is ultrasound machines are expensive, generally speaking, certainly if you want to get a good one. They are the learning pathways, the postgraduate certificates, even our SMUG courses, all the other courses that are out there are not cheap. For a reason they're not cheap, but you need to ensure that before you embark on this, you are fully on board with how long the learning pathway will be, what the financial commitment will be, and just as important as that, what the time commitment will be. Because as I've been saying to the guys I've been teaching today, you can't simplify this. This is just something that takes time and needs supervision, support along the way. And the other big thing, and I know there's lots of practitioners that are working in private practice. I'm very lucky where I work that we now have a good volume of injections, but without that NHS experience before, I would not have got good at injections. I wouldn't have got the volume through at all. And from a Complete Physio point of view, nobody can inject at Complete Physio until they've done 250 ultrasound-guided injections. You're not going to get that in private practice. So the guys that inject with us have gone through the NHS route or have picked up a few days along the way in radiology or et cetera, et cetera. So those are the sorts of things that you need to think about before you embark on things like postgraduate certificates, because you will get accepted on a postgraduate certificate. That's not a problem. But there's lots of people that start this journey and don't finish it because they have, and waste money and time because they haven't thought about what their specific learning pathway is. And have they got all of those components in place at this point before they even start? So there's a few things to think about there. And as I say, before you do embark on this training pathway, just go and get as much information as you can. Ask people. There's lots of good resources out there, but quite often, and what I find, I speak to lots of people about their own learning pathways, and it varies with everybody according to what their machine access is like, what patients do they generally see, et cetera, et cetera. So that just gives you an idea. So what might be a good idea now, Jack, now we've talked about that, is to go through some of the questions, and whether you just want people to ask questions, or we could go through the list of questions. Okay, so should we start with Daniel Jones? Are people going to ask questions? Can we speak to people, Jack? Or?
Yeah, so everybody who's on the call, we do have some pre-submitted questions, which I'll go through with Chris, but equally, if you've got any burning questions which have come out of Chris's presentation that you'd like answered, just pop them in the Q&A now. But while we wait on that,
Shall I do
Daniel,
shall I do the first one, Jack, from Daniel?
yeah, absolutely.
Is Daniel there? Okay, it's a good question anyway. So Daniel's asked, do you need to be CASE accredited? So CASE is a voluntary organisation that accredits some courses. It's very much built out of sonography. So the relevance of that to a clinician that's learning ultrasound, it's not always relevant. CASE accreditation refers to diagnostic ultrasound. It doesn't refer to ultrasound-guided injections. Okay, so this isn't specifically about injections. That CASE don't accredit or don't have, from my understanding, have too much involvement in the ultrasound-guided injection pathway. But what CASE do is they accredit certain postgraduate certificates. So if I was a sonographer, I would only do a postgraduate certificate that is CASE accredited. Okay. For everybody else, now I run a postgraduate certificate that at the moment isn't CASE accredited, but to get a postgraduate certificate through a university is a very time-consuming, very robust, very academic process. So if there is a postgraduate certificate out there, it has already been through a very robust process in terms of your learning needs, what you need to get out of it, etc. So the answer is, if you're going to work at some point in the NHS, particularly if you're a sonographer, then you may need to consider whether you should do a CASE accredited course. But there is nothing out there saying that it needs to be CASE accredited, other than if you work in the NHS, and it may say that, it may not. So you just need to think about whether it's something that you're going to need at some point. If you work in private practice, you don't need to go to a CASE accredited course. I don't know, maybe that answers it.
Yeah, brilliant. So another question that was in the chat, I don't know if you can see it, is I'm guessing they put, is this any good for sports massage therapists? I imagine by that they mean, is ultrasound guided injections good for sports, or is it possible to carry out as a sports massage therapist? I know you'd covered.
Yeah,
Chris,
that's really easy. No, it's not.
Sure.
Yeah, it's not. There's a couple of questions that I saw. So one thing that lots of people asked was about, so one person said, is there a formal training pathway for ultrasound guided injections? And the answer is no. It depends what your profession is, what your job is going to be in the future, what your local guidelines say, if there are any. I always do say that ideally you should try and aim to do a postgraduate certificate as a learning pathway. It's accredited, it's academic. But to do any postgraduate certificate, you need a supervisor to sign you off, either for the ultrasound side of it or for the ultrasound guided injection side of it. And the biggest barrier, as I've said, is being able to get supervision. And the last thing you want to do is start a postgraduate certificate and not have a supervisor, because you're wasting your money. So we do a mentorship program for diagnostic ultrasound, and you don't need a supervisor for that. And it's very much about teaching people how to scan. We meet up every month for 7 months. There's an exam at the end of it. It's not accredited, but I see that people that do that pathway really do learn how to scan. The negative is that you don't get the academic side of it. But certainly at the end of the day, nobody's saying you need to do a postgraduate certificate to scan as a physio or a doctor to carry out diagnostic ultrasound. But what you do need to show is a learning pathway. So you need to have attended the right courses. You need to have a logbook of your scans. You need to have reflection of your learning. It's exactly the same as if you were trying to prove your competency in neck manipulation. If you've got no evidence that anybody's ever taught you and that you haven't reflected on it, and you don't maybe have examples of your care, then what have you got if somebody tries to sue you? And it's exactly the same with ultrasound. So you've got to, it's not a question of buying an ultrasound and just waving it around and seeing how you get on. There's got to be evidence of your learning, and it's got to be a lot more specific and thought out than that.
Great. Thanks for that. I'm just looking at some of the questions here, Chris, and I know just going through some of them, and your presentation has actually answered a lot of them. One of them, which I know that me and you have had discussions with, is when starting out in diagnostic ultrasound, are the cheaper handheld devices a good option? If costs are a concern, then if you wanted to share your opinion on that.
Yeah. Well, I mean, as I get that I've had the question today. So let's be clear that ultrasound machines have, in fact, let's start with this. Anybody that's any good at ultrasound doesn't want to use a handheld machine. Okay, that's it. If you said to me, I've got a handheld machine, I hardly use it because I've got better machines. I totally understand that ultrasound is quite expensive at the beginning, and without a machine, you're not going to get anywhere. So I do believe there's a role for handheld machines. And they've come down in price. They're now sort of, the two best ones are the Vscan Air by GE and the Clarius. Now, and they're both around the same price. I think the Vscan Air is a little bit cheaper. And, they sell it to you. You've only got to Google it once and you get, adverts on your screen for the rest of your life, pretty much. So, they are targeting people that don't know what a good machine is, or at least, and they're targeting and marketing it as crystal clear images. Now, they are crystal clear images. I always wish I could write in brackets for a handheld machine at that price, because that's what the disclaimer should say. And so I don't want to be too negative, because I think they're a really good way into the market. But when you get good at ultrasound, which probably happens within 1 or 2 years if you're scanning well, then I promise you'll want to upgrade that machine. And so it is that whole thing, and I've written loads of articles and there's stuff on YouTube about it, is that if you buy cheap, buy twice. So you either just spend that 10 to 15 grand now, which will probably do you for the next 10 years, or you buy something to get started, and then I can guarantee at some point you will want to upgrade. And don't get me wrong, the handheld machines are incredible to what they used to be. Absolutely incredible. But in ultrasound, you totally buy, you spend 15 grand, you get a much better machine if you spend 5 grand. There's no secret out there that some people know and some people don't. Do
you think the handheld ones initially for people starting out can be a hindrance because you get better quality with the other machines? So when you are learning, do you think that having the clearest image possible is going to accelerate your learning at a faster rate?
Yeah. So if you think about, can you still see my screen?
Yeah.
If you think about the beginning of your learning pathway, okay, you are as bad as you will ever be at ultrasound. Okay. Now, if you go and buy a machine for say 3-4 grand, which again, it's a good machine, very good machine for 3 or 4 grand, you're buying probably the worst machine you'll ever scan on in your ultrasound career. So you're as bad as you'll ever be. You're probably scanning on the worst machine you ever have. It doesn't make it that easy. Does that make sense? So if you scan on a top end Alpinian machine, you will see more, and it will be easier to learn than if you scan on a handheld. There's no argument around that. Yeah.
Okay, great. Thanks for that.
But at the same time, as somebody that wants to motivate people to get into ultrasound, if you can only afford 3 or 4 grand at the moment and you are fully aware of the limitations, then fine, get started, but just be aware you'll want to upgrade.
Yeah. So here I know that you've covered a lot of these questions, but somebody asked here, and this is Stephen Watson, who's a lecturer. He's put, if you can just touch on guided injections as treatment versus exercise for chronic MSK pathologies.
Yeah, I mean, it's a very big topic, isn't it? I think I'd have to change the title of the webinar, but I don't really know what the question is, because the answer is that, for chronic problems, exercise is absolutely the cornerstone of the treatment. However, in some cases, there is a role for ultrasound-guided injections. I mean, I think that probably, unless there's, I mean, you know, what you've got to be careful with is that when you do have the skill of ultrasound guided injections, is that it's that whole thing, and we've all got our own biases. I totally understand that. So if you come and see me, you're more likely to have an injection than if you came and saw somebody that doesn't do injections. So we've got to be careful of our own biases. But I do believe that for some chronic, what was it? Did he just say chronic MSK conditions?
Yeah, pathology.
Yeah. I mean, yeah. So, you know, if you look at an Achilles tendinopathy, if you look at patella tendinopathy, if you look at an arthritic knee, you know, things like that, I go in with it. I don't want to inject that. I really don't want to, because it's not going to be the mainstay of treatment. And if you give them a bit of pain relief, they probably then want a little bit more when it wears off after 3 or 4 months. And if you do that, you give them the reliance. And in the end, that's a very slippery slope. However, if somebody walks in with a de Quervain's tenosynovitis, somebody walks in with a trigger finger, if somebody walks in with carpal tunnel, frozen shoulder, you know, these sorts of things, those are the things that I think an ultrasound guided injection is very relevant for. But what's great as a physio is we are doing that package of care, aren't we? So, you know, within my clinic, we have lots of physios that specialize in rehab, and then we have myself that does diagnostic ultrasound guided injections. And I think having that sort of multimodal approach and having different options is really important. The thing I would say about exercise is, if you look at people, and I'm a physio, but, you know, one thing we have to be aware of is we say, oh, Achilles tendinopathy, you just need to do rehab. The evidence shows that 50 to 60% of people get better with rehab. There is still 40% not getting better. So, you know, we can't be black and white about, well, we should just do this, we should just do that. Every patient is different. Every diagnosis is slightly different, particularly when you start looking at ultrasound. So I think that probably answers it roughly.
Yeah, absolutely. Now, don't know if you've covered this. Someone's mentioned how many times can a patient be given ultrasound guided injections? Like, is there a limit to that
in terms of the number a year?
Yeah, they've just said, you know, is there a limit to the number of injections that
I mean, there definitely is a limit. Absolutely. I don't think I've ever injected anybody in my life more than 3 times.
Okay.
Yeah. So yeah, there's an absolute limit, because steroid is not, it's toxic for tendons, it's toxic for cartilage. So absolutely, this needs to be used very carefully. Patients need to be fully informed with all the choices that are available. Yeah, repeat injections are a downward slope. You really need to use these injections carefully and ensure that you're using it for the appropriate thing. But just as a caveat to that, is being able to do a good diagnostic ultrasound scan does help with that clinical reasoning side of it.
The one thing that came up for me, Chris, is I don't think this is just a question from me. You mentioned that obviously when a injection is guided and when it's not, if let's say that 50% of them or 20% of them aren't accurate and they don't hit that spot, is that injection then sort of invalid? Is it then not had any treatment for the patient if it isn't accurate?
Yeah, I mean, so if you don't put an injection into a joint, for example, it doesn't mean it won't have an effect.
Okay.
And that's where the outcome argument can be. However, I think it's a good start, isn't it, to get it in the right spot. But yeah. And so there is lots of evidence to show that it doesn't make any difference whether you do it guided or unguided. And that's why I like to make the argument that actually, well, it's when you add ultrasound into your into what you do, it's not just about a guided versus unguided argument. It's about the whole process of adding ultrasound into it and getting that diagnosis right in the first place.
Yeah. We've had a question come up from Gulam Adele. He's put, what's the pathway for ultrasound-guided injection for osteopaths? I believe this was covered in the presentation, was it? Or?
Yeah, well, no, it's a good question.
Yeah.
So first of all, osteopaths can't be independent prescribers. They can never prescribe a drug. Not part of the HCPC, not sure of the reasoning, but that's the case. So as an osteopath, you will only be able to do ultrasound-guided injections of things that are not drugs. So the two ones that spring to mind is hyaluronic acid, which can be used for arthritic knees, which is if you like, a lubrication. That's called a medical device. It's not a drug. And then obviously lots of people have heard of PRP, which is where you take blood, spin it, and you put the plasma into the area. And that, again, is not a drug. Now, just because they're not drugs doesn't mean you can just start doing it. The pathway is still exactly the same in terms of you need to be able to get your diagnostic ultrasound skills up and have evidence of that. And then you need to do some sort of injection course, be it unguided or guided. We've had osteopaths on our postgraduate certificate, and I know they're injecting things like hyaluronic acid. I always, my job is to teach people how to do it. What they inject is down to them at the end of the day. The thing that concerns me about osteopaths is how you're ever going to get the numbers through the door to get good at it. Because let's say it takes you 50 to 100 knees to get really good at it. It's going to take you a very long time to get that. Now, we run a 2-day cadaveric course. So we've got the cadavers, soft embalmed cadavers, and you get lots and lots of practice of injecting. And that's really good. But obviously, how are you going to get those numbers through your osteopathic clinic? The answer generally is no, because 70-80% of what you see may be spines. So you're not actually seeing the right caseload in the first place. Now, that will be different for different people, but that's my experience of speaking and teaching lots of osteopaths.
Mm-hmm. And I guess...
so just one other thing, actually. As you can see, I don't know if you can still see my screen, but on our website, that's the resources page. And one of the blogs I wrote is, can osteopaths inject? Can osteopaths carry out ultrasound-guided injections? So have a read of that. Yeah.
And what are the typical costs of your training courses, Chris, if you don't mind?
Yeah, so no, not at all. So most postgraduate courses up and down the country are £3,000 for the year. Yeah. The cadaveric 2-day course, it's all on the website, is about 900, just because they're very expensive to rent 6 to 8 dead bodies and a lab. But I must say, if you're, and I put that as a tip there, is that if you are thinking about doing ultrasound-guided injections, then at the very least, try and attend a 2-day cadaveric course, because you do get lots of practice of actually doing it, and we take you through the easiest ways of carrying out hip injections, knee injections, etc.
Yeah. Okay. Just a few more then before you wrap up. How long have you got, Chris? I'm just wondering, are we sort of...
Yeah, I'm up till 1:30. I don't know what the time is.
Yeah, a few minutes then.
Yeah. I'll just go on. I've got a few more slides, and yes, this is about our courses. So on ultrasoundtraining.co.uk, just Google SMUG courses. We've got loads of different courses for all different standards. What I would say is, if you're totally new to this, then the 2-day introduction course is the best course for you to get started. That will introduce you to all the other pathways that you can do. So that's one thing. And then obviously, as we were talking about injections, we've got 2 cadaveric courses coming up, all on the website, one in Leeds in May and one in July, and the September cohort for the postgraduate certificate. But if you have got any questions, and actually this is actually quite a unique course. This is a 1-day shoulder course. So if you're just interested in shoulders, which we often get a lot of orthopedic surgeons that just want to be able to do these sorts of things, or special interest physios in orthopedic triage, is we're having a 1-day, and this is at Twickenham in partnership with England Rugby and their medical guys there. We're doing a 1-day, which is the morning is how to scan the shoulder, and the afternoon is how to inject it. And there's loads of, our YouTube channel's got loads of free videos, and they are really good teaching videos. That's my mobile, that's my email if you've got any questions. There's loads of information on the website.
Amazing. Got some people asking how, I guess, more of a practical of how to go about actually just finding mentorship for the training. They're saying that, you know, this is proven very difficult. You know, have you got any general advice about how people can, you know, techniques how they can, I guess, establish and find a mentor?
Yeah. So I'll give you 3 examples of how people have done it. Okay. The first one is what I did, which is there was a group of 4 of us, and we bought in the time of an expert every 2 weeks. The NHS paid for some of it, but actually we did quite a bit of it out of our own pockets. And so there was 4 of us. So if you can get, I say, try and get some ultrasound buddies. So if there's people in your local area, try and get together. And if you haven't got the local radiologist that you can just go and scan with, which the reality is most of us won't have that, then think about getting an expert in to come and spend some time with you. So that's one thing. The second thing is we have the SMUG mentorship, which is really the only mentorship program in the UK, really, on real patients, because we do it at the British School of Osteopathy, which is the University College of Osteopathy now. So that's the other way of doing it. And then obviously the third most obvious way of doing it is to try and become matey with a local radiologist, sonographer, physio, that sort of thing. Somebody that's going to be able to mentor. The problem with mentorship is if you think about ultrasound in this country for MSK, think of it as a pyramid. You've got lots of people learning, but you haven't got a lot of people at the top. And the other thing is mentorship is very, very time consuming for the mentor. So I've mentored lots of people, but it takes an awful lot of time up. I mentor the guys that work for me at Complete Physio to get them through their postgraduate certificate. And every Wednesday afternoon, apart from today, because I've not been there, we've had patients coming in and they're scanning, I'm watching, then I scan, doing a bit of an audit of how they're getting on and that sort of thing. But it's very, very time consuming. But yeah, there's a few examples there of what people can think about.
Well, on that note, Chris, really appreciate your time and everything that you've shared. Will this, you mentioned that, will these slides be available to
yeah,
well, obviously we've recorded, haven't we, so we can send out the recording, but then equally if someone wants to study the slides, that can be sent to the participants of tonight?
Yeah, absolutely, that's no problem. If they just contact me, I can send it. The other thing I would say is I do spend quite a lot of time speaking to people about learning pathways. And their specific situation, and trying to think about what would work for them. Yeah, I've certainly stopped people embarking on it in the first place because they're just not set up to do it, or maybe they need to think about, you know, doing it in a few years. So I'm happy to speak to people. My details, they can contact you guys and you can pass on my details, or contact me directly through the website on those details, which are there.
Great. All right. Well, look, really appreciate that, Chris. I'm sure everyone took a lot of value from that. And yeah, there's Chris's details. So feel free to reach out. And of course, you can reach out to PhysioQuip as well. And we're happy to help you as much as we can and put you in touch with Chris.
Cool. Thanks, guys. Thanks, Jack.
Cheers.